So look, it's I think I'm due to introduce you, Barry, which is my very great pleasure and distinct privilege to do. President of the Society, very distinguished colleague, who's going to give his talk, COVID-19 and Thrombosis, sponsored by Sanofi.
So my honorary, these are my disclosures, and this talk is sponsored by Sanofi Aventis, and therefore I'm duty bound to put up a slide saying that these are my ideas and not their ideas, and you can't sue them if I say something they don't agree with. But once again, thank you to our sponsors for sponsoring this meeting. You've all seen the slide on numerous occasions, and I think it's pretty relevant, and I think Trudy brought up the point is that previously in medicine, rational proof as in mathematics, and this is homage to one of my heroes, Maimonides, perception by one of your five senses. And unfortunately, in this COVID epidemic, what we are doing is basically tradition derived from the prophets and the righteous, because we have very little hard evidence to say what we are doing. And as Harry Bueller always says, in God we trust, everyone else show us the evidence. Well, you all know that the endothelium plays, and we've spoken this on numerous speakers have spoken about the critical role the endothelium plays, but more than nearly 200 years ago, Virchow stated that to get thrombosis, three things needed to happen, and that was basically stasis, stasis, endothelial dysfunction, and change in the consistency of the blood. And while we've always known that thrombosis is a critical role, what about inflammation? Because the buzzword currently is immunothrombosis. And the earliest evidence that, and as clotists or thrombosis people, we've known for a long time that the coagulation system co-evolved with the inflammatory system. So one very seldom gets coagulation without thrombosis, without inflammation, and vice versa. And the primary example of this is the horseshoe crab and primitive organisms. We know that the coagulation system co-evolved with the inflammatory system and diversified about 400,000 years ago. But if you take a few seconds just to look at this slide, and you can see here the coagulation cascade, and on this side we have the complement cascade that Dr. Susan Loeb discussed in somewhat detail. I'm not going to go through these in any detail, but suffice to say that these are almost identical. And what one sees in the coagulation cascade, in the factors here versus the factors here in the complement cascade, is they're just different Lego blocks put together in a different way. So the idea that you get coagulation without inflammation is actually very, very rare. And it's been brought to the fore, our knowledge has been brought to the fore more, or rather enhanced by the fact of this COVID epidemic that we have now faced. And they talk of immunothrombosis, and it's not really limited to the neutrophils. So you have a stimulus, in this case, a pathogen. And one of the factors is activation of the neutrophils, but at the same time, activation of the complement cascade together with the coagulation cascade, and ultimately causing so-called immunothrombosis. And one can see here the SARS virus causing an alveolar effusion. The macrophages get activated, neutrophils get activated, the so-called nets, neutrophil extracellular traps, and then forming these microthrombi and macrothrombi with the release of D-dimers into the body. And this is from the Lancet article. And this is brought together from the quite nicely here to show you have an excessive immune response with the so-called cytokine storm, resulting hypercoagulability, damage to your underlying endothelial cells, leading to a macro and a microthrombosis with the resultant hypoxia, which is the major problem that we face in these unfortunate patients with COVID. Very early on, it became known that D-dimers seem to predict survivors versus non-survivors. So the D-dimer elevation was well established quite early in the disease in the Western world, that this was a problem which resulted in a poor outcome. And this seemed to mirror almost identically the rise in IL-6, suggesting it was an immune response at the same time that we were getting these raised D-dimers. And this has been shown over and over again in multiple other studies showing the disease severity and prognosis is associated with a rise in D-dimer. And it became a and time precludes us for going into this in any detail. What was fascinating was the fact that from the Chinese experience, this 0%, they were seeing no increase in, VTE. So the Dutch, and this is from Professor Klock, and these are his slides, and the Dutch have always been very good at thrombosis, Harry, and they came out, in their experience, they had a incidence of 31%. And what's fascinating is that it was predominantly VTE and stroke, but this VTE is driven primarily by underlying pulmonary emboli and not deep vein thrombosis, which was interesting in its own right. So 16.7% in the Dutch experience. Sorry, this was in the French experience. The Dutch had the same experience in sort of 20%. And PE seems to be the primary driver behind this thrombosis. And DVTs in some patients, and interesting stroke patients, and we'll come back to this, and renal replacement clotting. So in other words, an ECMO occlusion, and we've seen that a lot in our patients, occurs in this patient, suggesting there is definitely a hyperthrombotic state occurring with this disease. And one can see here, this is from France, that it's primarily driven by pulmonary emboli. And this is despite being patients of the patients who had PE diagnosed at the time of diagnosis, the majority of the patients were receiving prophylactic antithrombotic treatment. So it didn't seem to be adequate for this group of patients. If we look then at Saskia Middeldorp's study, one can see that it increases over time, that the longer the patients are in ICU, the higher the incidence is of symptomatic VTE. And just a point here is to point out once again that the majority of their patients developed thrombosis from the Helm study, developed thrombosis in their renal replacement therapy, suggesting that thrombosis is a primary problem occurring in COVID. Once again, just to look at this, just to see here that ischemic stroke seems to be playing a role, and myocardial infarction seems to be increased in this group of patients. And the study from the NEJM showing mainly large vessels that are infected, right internal carotid artery, middle cerebral arteries have been implicated in strokes. And this is a picture from Ian Lander, thank you, Ian, of one of his patients that had a peripheral arterial thrombosis. We've seen, and this is from our patients at Mill Park, patients on ECMO with COVID toe and severe ischemic disease of the ischemic vasculitis, actually, of the toes. And this is one of our patients with COVID during the height of the epidemic, in the hands as well. But the primary problem remains the lungs. And this is, I think, the landmark article that will go down as the way forward, the true people that discovered what was going on with COVID from the NEJM. It was done by German, Dutch, and Americans. And this is the lung, and one can see here the lung tissue, the lungs being fibrotic, and one can see here, so I need to go back. One can see here thrombus actually in the alveolus, which is amazing. Microthrombi occurring. These are not macrothrombi, these are microthrombi that one can see in the lungs. And this shows the normal underlying tissue, the support tissue of the lung, and how grossly distorted it becomes with COVID, mostly due to interceptive neoendothelialization. So the endothelial cell grows in sheets and changes the underlying structure. And in this slide, you can actually see virus inside the pneumatocyte. The histopathologists have come up with 4 distinct patterns, so-called endothelial pattern, where there's where the predominant is endothelial damage, then a thrombotic pattern, and on this side we have an inflammatory pattern, and they all can lead up to this fibrotic pattern, which is a terrible disease to have, where these patients are basically non-ventilatable despite being on ECMO. So the question is, can anticoagulation actually help these patients? Well, early on it was shown that anticoagulation is associated with a decrease in mortality. decreased in mortality. And if one looks at here, this, let me just pick that on my side, that we can see here, obvious decrease in mortality, increase in survival in patients who received anticoagulation. So there is definitely a role for anticoagulation in improving outcomes in these patients. The question is how much and how long. And the other point is that we've shown that you can decrease that routine VTE prophylaxis doesn't seem to be adequate for these patients because they're still getting VTEs in this group of patients. And Trudy spoke to this, and this is the guidelines. So if one goes to the guidelines, there was a paper published recently looking at the 5 international guidelines, and there's complete discordance in what to do. So all the experts don't really agree what to do. So then how are we supposed to know what to do? But each expert committee has decided for themselves that this is what we should do, and we don't really have hard data. The one data that I think is quite critical, and that was about the D-dimers, and having survived COVID myself, telling your D-dimers went up markedly, that I think one should be measuring D-dimers, and that if the D-dimers are elevated, then these patients, I think, really do need anticoagulation. And from a personal point of view, I upped my anticoagulation until that D-dimers had actually normalized. But unfortunately, there's no hard data to do this. If we're looking at current studies that are currently underway, and these are just some of the studies that have been out, and there are numerous studies, but we don't have any real hard data yet of the randomized studies to know what to do for these patients. And in the remaining minute, I would like to briefly discuss the study that we're involved in, where AJ has been the lead, and that's the so-called ethics study, which is an early thromboprophylaxis in COVID-19 patients. And we had the first patient in the world on the study. This is a community-based study where patients who are well enough to go home are being treated with enoxaparin or nothing and for 21 days. And we are trying to see the outcome of these patients. It's an open label, multi-center, multinational study. Just a point of interest is that we looked at patients that for the doctors who treating COVID, that your risk of getting COVID is not small. We had a positive rate at the CTICU of 30%, and unfortunately, one of our people who's recruiting in Belgium has picked up COVID. So treating COVID is not without risk for us healthcare practitioners, but the study will include patients who are older than 55 who have two additional risk factors. They're either older than 70, they are have a high body mass index, or they've got underlying lung disease or cardiovascular disease, diabetes, or corticosteroid use. So in summary, Mr. Chairman, COVID-19 is associated with both a micro and macro thrombosis. We believe patients in hospital definitely require anticoagulation. On a personal note, I believe that we should be monitoring their D-dimer levels, and they should be at least at therapeutic levels. And I do believe in monitoring at this stage, although we don't have hard data. The question is whether thromboprophylaxis, and that's another point of our studies, is looking at pulmonary emboli as a hard point and not really at lung fibrosis, whether or not we can reduce the lung fibrosis, or whether or not we require additional agents, such as drugs that reduce your nets, such as colchicine. I know there are trials that underlying that, and persantin, and that remains to be seen. But there is a large elephant in the room. We know that, unfortunately, the UK and Northern Europe and the USA have got a terrifying second wave at the moment, and whether or not we will ever get back to a peaceful state remains to be seen. Thank you.
Barry, thank you very, very much indeed for that marvelous talk. I mean, you rightly mentioned the ethics study that we're doing together, which is, I think, the only, as far as I know, there may be one in the United States study recruiting patients soon after diagnosis, whilst they remain in the community, to determine the impact of early anticoagulation on the natural history of disease. Can I ask you a question? There was a paper in Science recently that suggests that the coagulopathy in these patients looks to manage the hypercoagulable state associated with COVID, even if it isn't associated with symptomatic intravascular thrombosis, as opposed to using a low molecular weight heparin.
AJ, sorry, you disappeared halfway through the question. I only got the very end of the question.
I was going to say that there was a paper recently published in Science, which formed the front cover of Time, that suggested that the pathophysiology of the coagulopathy in COVID-19 might look a little bit like a antiphospholipid syndrome. Under the circumstances, if that were to be the case, what would your view be about using direct oral anticoagulants versus low molecular weight heparins in these patients in terms of managing their anticoagulation?
Well, I think that's a very important question, AJ, and thank you very much. I have seen that paper where there's been quite a lot of patients. I mean, up to 50% of patients got antiphospholipid syndromes. I think the concern is, given the fact that our management of patients with antiphospholipid syndrome with DOACs has been somewhat disappointing, and they actually had to stop 2 of the trials where we had to actually think of, although we still got some patients on them due to the fact that you can't really, they really are unmanageable on warfarin. And I think that would be a further reason why low molecular weight heparins would probably be beneficial for this group of patients as opposed to the DOACs, given the lack of efficacy in the trials for the DOACs, would be my personal belief. But maybe we can come back 5 minutes earlier after the break. So we'll take a 10-minute break and then